Welcome to the CVI webcast on COVID-19 testing. We have an esteemed panel here today to take us through the various questions we all have in our minds regarding the testing part of this entity. And that's why we have, of course, personally for me, maybe many of you are more aware, have termed it or titled it Cutting Through the Clutter. So let's bring all our cluttered questions after a brief introduction and a few formal words from each one of our panelists. Let me introduce you to them. So first is Dr. Robin Patel. She is the Director of Infectious Disease Research Laboratory and Chair, Division of Clinical Microbiology at Mayo Clinic. And she is also the current President of the American Society of Microbiology. We also have Dr. Sunil Rao, well known to us in our fields, Professor of Medicine at Duke University School of Medicine. He's also the Chief of Cardiology at the Durham VA Medical Center and the Editor-in-Chief of Circulation Cardiovascular Interventions. We also have Dr. Gregory Storch. He's the Chief Division of Pediatric Laboratory Medicine and the Medical Director and of Clinical Laboratories at St. Louis Children's Hospital, Washington University Physicians. And this discussion is going to be moderated by my esteemed colleagues, Dr. Emmanouil Brilakis, Dr. Mehdi Shishehbor, Dr. Sorajja may join us, and myself, Dr. Subhash Banerjee. And I can tell you that this COVID-19 testing questions have featured prominently in a recent survey conducted by our foundation. I'll share very briefly some of the findings. And this is one of the questions we asked about 500 surveyed interventionalists from various countries and mainly from the US and Italy. And they were quite concerned about various aspects of their care at the hospitals and being at the hospitals and healthcare facilities. And as I just want to let you know that they were allowed to pick multiple options here. But in red, you can see that the fear of viral transmission featured quite prominently. And I'm not going to take you through the entire survey.
Sorry, Subhash, we don't see the slides you're referring to. I'm sorry.
You're not seeing the slides. So let me just share them with you one more time. Can you see them now?
No.
Okay. So sorry for this little glitch, but let me try this one more time. Kelly, can you share it by chance?
There you go. Now it's coming out.
Okay, very good. So I think let me go through and move forward, Kelly, to the survey results. And you can see that a significant number of the respondents did mention that the fear of viral transmission featured prominently amongst their concerns. And I won't take you through the entire survey, but the indications and the types of testing was another area where we received a quite diverse number of responses from the international community. And we wanted to gather those questions and feature it during this webcast. So this webcast will not be a long didactic presentation. It'll be more some concepts introduced by our panelists, and then a moderated discussion, and then your questions will feature prominently throughout the webcast. So please feel free to use the chat lines. We already have over close to 150 attendees, 137 attendees right now, and it is growing. And please use chat lines. And while I'm moderating, or Dr. Shishehbor or Dr. Brilakis is moderating, either one of us or each one of us will also be looking at the chat lines. I also invite our panelists to respond to the chat lines, and if they see a question that is appropriate and they feel engaging our audience. So please keep your questions coming, and we will feature them as soon as we get to that part. So without further ado, Kelly, if you can move the slide one forward. We are going to introduce the agenda. It will start off with an introduction by Dr. Robin Patel about the available COVID-19 tests. She'll speak very briefly about the virus, the SARS-CoV, the SARS COVID coronavirus 2 virus and the available test. It'll be followed by Dr. Gregory Storch's brief introduction to the available application of these tests, and followed by my dear colleague, Dr. Rao's a brief synopsis of what are the major concerns and how and what does the cardiovascular community, what kind of question does the cardiovascular community have while they get back to what we can call the near normal, or when we get towards normalcy, and how these tests will be deployed in a cardiovascular practice. It'll be followed by a moderate panel discussion by myself and my co-moderators, and then a full range of audience questions. But please be aware that we are going to feature your questions predominantly during each of these sessions. So keep them coming, and we would like to have this become a very interactive session. Without further ado, let me call upon Dr. Robin Patel to take us through a brief description of the SARS coronavirus 2 structure and its basics, and also introduce us to the available tests for COVID-19.
Absolutely. Thank you so much. It's a pleasure to be here and to talk to you about diagnostic testing for the virus called SARS-CoV-2, and the disease being COVID-19, so sort of the same thing with two different names. Before this virus emerged, most clinical microbiology laboratories had tests for coronaviruses, but these are different coronaviruses. They're the coronaviruses that cause the common cold and sometimes more severe respiratory illnesses like coronavirus 229E, HKU1, NL63, and OC43. So that's something that can be a little bit confusing. Those are different coronaviruses that cause the common cold. As you likely know, there's also a virus called SARS coronavirus, which was the one that caused disease back in 2003 and is no longer circulating. And there's another coronavirus called MERS, which is circulating at low levels in certain countries, but is not really a problem right now in the United States. But we have dealt with that coronavirus as well. This coronavirus, SARS-CoV-2, emerged around November of 2019. And at the time, obviously, we had no diagnostic tests for it. Importantly, the diagnostic tests to detect the other coronaviruses that cause the common cold don't pick up this coronavirus. And that can be really confusing because we tend to use the name coronavirus today as if there's only one coronavirus, but there are many of them. So speaking specifically about SARS-CoV-2, we have two approaches to detecting the virus that are commonly used today. There may be others in the future, but two that are commonly used. One is tests to directly detect the virus through detection of viral RNA. Obviously, we can culture this virus, but that's very dangerous and slow. We don't have viral antigen tests that are in common use. So really the go-to test for direct detection of the virus are tests that detect viral RNA. And I'm going to talk more about that in a minute. And then the other category of tests that you've heard probably a lot about in recent days is serologic testing, where we detect antibodies to the virus, typically in patient blood. And I'll talk more about that as well. But we'll focus most of what we're talking about on tests for viral RNA. Kelly, can you advance the slide? Thanks. I am the president of the American Society for Microbiology, and that includes a large number, over 30,000 microbiologists, including a large contingent of clinical microbiologists that direct and oversee the testing for infectious diseases throughout the United States and actually throughout the world. And on March 23rd, the American Society for Microbiology convened a symposium to talk about research needs and needs of our members in the area of SARS-CoV-2. So obviously we talked about vaccination and therapeutics, but we also talked about diagnostics. And as a result of that, we published a study in Mayo, which is one of ASM's journals on testing for SARS-CoV-2, COVID-19. And this is an infographic that comes from that publication that derives from the summit that was held on March 23rd. And even though things are changing rapidly, and I was a little bit nervous that now, you know, a month later, this might not be correct. I think it's more or less still correct, which is amazing after a month because things are changing so fast in this epidemic. So this infographic talks about the types of tests. Again, on the top are tests for viral RNA. These are nucleic acid amplification tests. So PCR is an example of that, but there are other technologies that can be used to amplify viral RNA. It's the same type of testing as we do for other viruses like influenza, for example. Important to the discussion is that there are a variety of different specimens that can be tested, including, for example, nasopharyngeal swabs, oropharyngeal or throat swabs, sputum, bronchoalveolar lavage fluid, and other types of specimens as well. And what these tests detect is the RNA of this virus. They don't tell you that the virus is alive, but they give you an indication that the virus is present because its RNA is present. And they're used to inform individuals of infection status so that they can take an appropriate course of action in terms of managing their illness and prevention of transmission of the virus. And obviously they are useful in healthcare facilities, and I'm sure there are going to be lots of questions about this, as well as long-term care facilities, to determine who's infected and who might not be infected, to inform patient management and also take actions to prevent transmission to other patients or to healthcare workers. And then from a public health standpoint, they can also be useful to identify those who are actively infected, or at least potentially so, and inform actions needed to prevent transmission. On the other hand, antibody detection is your other way of testing for this virus, but there are a lot of caveats about this. First of all, we don't normally use antibody detection for acute respiratory illnesses. Think about influenza and RSV, for example. There could be serologic testing, but that's just not something that's done very commonly because you have an acute illness and you really just want to make an acute diagnosis. And antibodies, as you know, take some time to develop. And so they won't be present immediately, typically in your patient presenting with their symptoms in the first instance. And so they're not really very useful unless you're doing some sort of follow-up on that patient with serologic testing. But in the case of this virus, what they can do is, in a patient who's been previously infected, give you evidence of past exposure to this virus. And potentially this can be useful to detect people who are susceptible to the virus who haven't been infected in the past, and those who have been previously infected. If, for example, there's protective immunity, and we don't know for sure whether or not there is protective immunity, then that could be helpful to identify those who have already been infected who perhaps could return to work or return to contact with patients who have infection with this virus. Also, antibody testing can be used to identify individuals who might have neutralizing antibodies that are being used as potential investigational therapeutics and are currently under study as one of the many potential therapeutics for SARS-CoV-2. So essentially to identify your donors for those antibodies. And then of course, public health can use antibody testing for contact tracing and surveillance, probably not so much of interest to this group here today. But importantly, I think we should emphasize what antibody testing is not useful for. It's not really very useful when you're trying to diagnose acute infection, because again, antibodies typically will not have developed by that point in time. So I'm going to pause there and take questions. I see questions kind of popping up. So one question is, what is the false negative rate for viral RNA testing? And that's going to vary depending on a number of factors, including how well the specimen was collected, what type of specimen was collected, where the patient is in their illness, because the levels of virus change over time, and maybe based on individual factors as well. And of course, it could vary potentially depending on what assay is used. If an assay that's less sensitive than another assay is used, that can make a difference. Another factor that we have learned is that you can test nasopharyngeal swabs, or you can test lower respiratory secretions. In some patients who have pneumonia, we detect the virus in their lower respiratory tract secretions, but not in their upper respiratory tract secretions. So if you have a patient with pneumonia who you're suspecting has this, and their nasopharyngeal swab, for example, is negative, you should move on and test a lower respiratory tract specimen like sputum or bronchoalveolar lavage fluid. So I'm going to pause there because I'm not sure how long I'm supposed to go on for, or if we're holding questions to the end.
Robin, this is a perfect prelude to our discussion. We want to do some opening statements and then go on to the questions. Mehdi and Manas, do you agree with that? I think it'll be worth setting the stage with the facts first. There are lots of questions coming in.
Sure.
Okay.
Sure. That's great. Then.
I think we should move to Dr. Gregory Storch. Kelly, Dr. Storch invites you again, and thanks for sharing your time with us. We want to take, we would like you to take and pick up where Dr. Robin Patel left and tell us a little bit about some of the metrics of these tests, how sensitive they are, how specific they are, and what are their false negative and false positive rates, and which are the tests that we specifically would be using when we get up and started, when the hospital practices start. So a little bit about the comparative values of these tests and which tests are most appropriate and in whom, and most importantly, how often to test. If I do a test and it's negative, do I have to retest myself again? So I think just take those, and these are not Q&As, these are just your opening thoughts.
Okay, I think really the important thing to keep in mind is that we're talking about two very different tests that are different tools that both will be useful, but they'll be useful in very different ways. So as Dr. Patel described, the first category of tests are the ones that we've had for a while now. Those are PCR-based tests that are tests for the presence of the virus. And you can think of them as primarily useful for diagnosis. They are used primarily on symptomatic patients to determine if that patient is currently infected with SARS-CoV-2. They are not used to determine the prevalence of the virus, how common the virus is, because they only reflect the status of a person at that particular moment in time. And the person might have been negative yesterday and positive today, or positive today and negative tomorrow. So they reflect a transient period of time when the person is positive for the virus. They are not particularly useful in people who don't have symptoms. So they would be used mainly for symptomatic patients, and they can also be used as a tool for outbreak control. If you envision, let's say, a nursing home that's having a problem with COVID, public health authorities might go in, and they might want to determine who in that nursing home is infected at that moment and who isn't, so they could potentially separate those groups of patients or use different sets of precautions. So the virus tests would be useful in that setting. Now, the antibody tests, which are just starting to come online, are very different. They reflect a person's past experience with the virus. They're not positive until the person has been infected for 7 to 10 days or so. Then they become positive, and they would stay positive for some extended period after that. We don't know whether that's months or years, but in some viruses, it can be as long as for the lifetime of the individual. Now, often when you do a serologic test and get a positive result, you don't know whether that's from an infection years before or a very recent infection. Here, we're dealing with a very specific situation of a virus that has newly made its appearance. And so if the serologic test is really one that is specific for SARS-CoV-2, if it's positive, that means that the person has been infected sometime during this outbreak because the virus wasn't present before that. Now, I did want to qualify that by saying that that must be a test that's only true for a test that is specific for antibodies to SARS-CoV-2. And one of the very important separation points of some of the different serologic assays is that some are specific for SARS-CoV-2, but some, and this is generally not a desirable feature, may also pick up antibodies from the seasonal coronaviruses that Dr. Patel mentioned. And so as a discriminating user, you want to distinguish between antibody tests that are specific for SARS-CoV-2, that would be good, versus antibody tests that may, in a sense, be non-specific because they can also be positive based on past infection with other coronaviruses, which are extremely common.
Fantastic. I'm going to ask you just one question before we move on to Sunil, and then we'll open up our question lines because questions are really filling up, and these are such pertinent ones that our colleagues and coworkers are asking. So my question to you regarding these tests is that imagine in a healthcare facility as we start opening up, and we are going to test healthcare professionals who are providing service to patients in these institutions. Should healthcare professionals or healthcare workers should be tested? And if so, what would be the appropriate test for them and how frequently should they be tested? Because there is an CDA's document on CDC's document about the priority of testing, and asymptomatic healthcare professionals are not on the top 2 tiers of priority, but that seems to be a concern. So Dr. Storch, should healthcare professionals who provide care as we become routine, as we open up for routine business in the months and in the weeks and months to come, should be tested? And if they should be tested, what kind of tests should be used and how often those tests should be repeated? I know it's a loaded question, but we'll probably get into it in more detail, but just your thoughts.
It's a little complex, but it is a very important question. So the virus test would not really be appropriate for testing asymptomatic healthcare workers, because think about what it tells you. It tells you whether or not that individual is positive for that virus at that moment in time. But it doesn't tell you whether the person is positive tomorrow. So you would theoretically, if you really wanted to define whether the person had active infection, you would really have to test them again and again and again. And it's simply not practical. For that purpose, I think we're going to have to use more symptomatic screening. Does the person have any fever? Do they have any symptoms? Recognizing that those screens are not perfect, but they would at least screen out some people who have symptomatic disease. Now, there may also be a role for doing antibody testing on healthcare personnel, but that would not be for determining who's infected at that moment. It would be for determining who has been infected. Now, one thing that we haven't mentioned yet is we still do not know whether a positive antibody test corresponds to immunity to the virus. In most situations, it does, and we're presumptively thinking that it will, but that is still a point that requires confirmation. Let's just say for the moment that a positive antibody test does signify immunity. Then you could imagine some value in determining whether healthcare personnel are positive or negative, because those who are positive might have some immunity and it might be safer for them to be involved on the front lines with patients who are potentially infected. Whereas those who are negative need to be considered susceptible and would be at higher risk for becoming infected.
Point well taken. Thank you. You also answered quite a few questions. Mehdi and Emmanouil, do you have any comments, or we move on to Sunil?
One quick question. I think it came up on the question list as well, that people are asking, let's say you do have antibodies, so do you still wear PPEs? I guess yes. But I guess the question is, should those people be preferentially taking care of COVID patients since they may be less likely to get infected?
Well, I think we have to emphasize that we're in the early days of antibody testing, and we don't know, first of all, we don't know really well whether an antibody test corresponds to immunity. Secondly, we don't know whether a specific level of antibody is required for immunity. And third, I want to mention a very problematic situation which is already developing, and that is that many antibody tests are becoming available, and they are of widely different quality. And some of them, as I mentioned, may detect antibodies to other coronaviruses, which would be irrelevant from the standpoint of immunity to SARS-CoV-2. Others may just be not very good assays. And we're going to have to come to a way of figuring out which are the assays that are good and which are the assays that are not. Unfortunately, the FDA at this moment in time is taking what I consider a very overly permissive approach and allowing essentially any of these tests to come on the market right now. And so we don't have the ability to say, yes, this is an FDA approved test or this is not an FDA approved test. Most of them on the market are not FDA approved. So we're going to have to look to other forms of validation to give us confidence that a particular test is really giving us the information that we think it is. So we're potentially entering into very treacherous waters with the antibody tests, at least in the near future.
Dr. Patel, do you have a comment on this very important question? You're muted.
Sorry, I have two comments about this. One, it is possible for an individual to have antibodies and still have detectable virus at the same time. So part of that question was whether that person would not be contagious anymore. And we do have to be careful, right? Because although we're saying don't use antibody testing to make an acute diagnosis, after a while, you know, by 2 weeks, but sometimes even earlier, antibodies will develop. And so you can conceivably have antibodies and virus at the same time. Now, if enough time passes, right, then the individual should clear the virus. But we don't want to take a positive antibody as evidence that the person couldn't possibly be infectious to someone else. So we have to look at the whole context of how that's being used. And then around the regulatory side, I realize that this group probably doesn't mind too much about these particular pieces, but as president of the American Society for Microbiology, I've been in regular contact and conversations and emails with the FDA regarding this situation. And I completely agree with Dr. Storch that it has been unclear what the regulatory guidance is around some of these tests. And we do want to make sure that first and foremost, whatever testing is used for this virus is accurate, is both sensitive and specific, because there are other coronaviruses out there, as I mentioned, and we've got to make sure that the antibodies that are picked up by these tests are antibodies against SARS-CoV-2 and not against other organisms, and obviously that they're also sensitive. I mean, this just makes sense, but we don't want to rush into antibody testing with poor quality tests.
Yeah, thank you. I just want to ask a question, Subhash, if that's okay. First of all, I want to thank both of you for raising this issue related to the FDA and their approval of some of these tests rapidly. I have seen the advertisement even on Facebook, people testing these things in their parking lot, and really concerns me. But my question was related to the point Dr. Storch made, that if you're asymptomatic, that we need to focus on symptoms, that it doesn't make sense. And I totally understand that from a testing standpoint. But I wanted to get your insights, because there is a lot of news out there in the literature and also in the social media that 30 to 40% of the folks that have this disease, this virus, are asymptomatic. And there is a good, I don't know if it's a hype or if it's true, and maybe you can highlight this, that a good portion of these, of the infectivity is highest when you're asymptomatic or pre-symptomatic. If you can answer that, is this true based on your experience and your expertise, that you are most contagious in the asymptomatic and pre-symptomatic period? And two, what are we supposed to do about this cohort, aside from PPE, which is also in shortage? What else do you recommend?
Well, these are somewhat difficult questions, but let me distinguish between asymptomatic and pre-symptomatic infection. We know from careful studies of the levels of the virus that patients will develop detectable levels and even high levels that are present for just a few days before they become symptomatic. That would be pre-symptomatic infection. Those individuals almost certainly are capable of transmitting infection. But that state of being transmissible is only a few days before they're symptomatic. Now, there's also evidence that some individuals are asymptomatically infected and may never become symptomatic. Those individuals, it's likely, have lower levels of virus, and it's really not all the way clear at this point how important those asymptomatic individuals are in transmission of the virus. But where the viral tests fail in trying to, you could imagine if you wanted to test a group of individuals and find out who has the virus asymptomatically, go ahead and do the viral test on them. And yes, it would tell who's positive at that moment in time and who's not. But the next day, the results would not apply anymore. So that's not going to be practical.
Thank you. Thank you, Sunil. Let me call on you, Kelly. You can advance the slide. You're seeing, Sunil, if you are following the chat rooms or the Q&A, there is already questions and comments coming in about how we are going to resume our cardiovascular services. I'm not going to ask you that question. We are all cardiologists and we are not experts in this field, but I would like you to become our steward and speak on our behalf of how do you think this transition to real life is going to look like? I mean, what are the concerns for the patients coming into the cath lab, to the echo labs, and testing of patients coming to the cardiovascular outpatient clinics? So take it away, and I'm not going to give you a particular format, but use this opportunity to highlight the concerns that the cardiovascular community is going to ask, and many of those questions, I said, have already been highlighted in the Q&A and the chat rooms.
Robin,
yeah, sure. First of all, I do want to say that I'm not currently in an area that has a very, very high infection rate. And I know that there are a lot of people that are currently on the webinar that are working in areas where their levels of infection are very, very high. And I just want to say to them that, you know, we're all hoping and praying that you all stay safe, and really appreciate all of your efforts on the front lines. I also want to just mention that I'm not going to be speaking for my own center. We're still working out exactly how we're going to be doing this. And certainly don't have any, don't want to be a spokesman for a professional society either. I mean, I'm really in the same probably position as a lot of the folks that are asking the questions. To me, the issues really boil down to two sort of big issues, which are, you know, what do you do about the patients? And then what do you do about the people who are working in the lab? We all need to get back to some level of doing procedures because we have patients who are waiting, who are becoming symptomatic. Clearly, there have been data that have come out showing that STEMI activations, for example, are much lower now. Patients are actually afraid to call 911. They're worried about coming to the hospital because they're worried about getting infected. So our priorities are to make sure that we protect the patients and make sure that they feel comfortable that they're coming to the hospital and it's safe. And then we also have to protect our own staff and ourselves to make sure that we don't have someone who is, as Dr. Storch said, pre-symptomatic and shedding very, very high levels of the virus. There are places around the country that are planning on going back to some degree of elective procedures, and some places have decided to test all of their patients. And other places are saying, well, you know, we're not going to test our patients. What we are going to do is put a mask on, a surgical mask on the patient after the initial sort of symptomatic screening. Have you had a fever? Have you been around anyone who's been diagnosed? Have you had a cough lately? Are you short of breath? Those kinds of things. And then have the staff wear masks, and then, you know, assume that that level of protection is about the same, or is sufficient, I should say. The option for wearing full PPE in every case simply is not feasible, as Mehdi mentioned. I think there is a shortage of that, particularly in areas that have very, very high rates of the infection. And so, unfortunately, I think if we had all the resources in the world, we would be able to do that. And I think we would want to test people repeatedly just to make sure that they're not pre-symptomatic, so we can actually figure out who would be a spreader and who's not. On the staff side, this whole issue of antibody testing is extremely interesting because it suggests, there's a suggestion, or at least a hope, that if you have an antibody like an IgG to SARS-CoV-2, then potentially you have a higher level of immunity, and you could be one of the first people to be taking care of the folks who had COVID-19 or potentially are PUIs. I think the challenges with that are many. The first of which we've been talking about, which is, what are the operating characteristics of these tests? How good are they? And then the second, potentially more important issue is, even if IgG is detected, are you really immune? And if you are immune, how long does that immunity last, and how quickly does it wane? I think what most people are doing who are healthcare providers who actually have had COVID-19, tested and are positive, they're still wearing full PPE when they're taking care of patients who are either PUIs or who have positive, who are known COVID-19 patients. And I think that's the right thing to do until we learn more. I think one of the challenges as a clinician, and maybe many of you are in the same boat, is that the amount of information coming out is just so voluminous on a daily basis, much of which is on preprint servers, so that hasn't actually undergone peer review, formal peer review in a journal. So you really have a hard time figuring out, particularly if you don't work in the field, what's real information, what's a flawed set of information. A lot of hay is being made out of the New York City study that just came out today on a preprint server. And again, you have to have a really good knowledge of epidemiology to be able to figure out what those numbers mean and what it means for your own practice. And then, I think Dr. Patel said this, what we learned yesterday may be proven incorrect today. So I think, those are the issues that are going through my mind as I start thinking about, opening up the labs to do elective procedures. I think there are higher risk procedures for us, like TEEs. Technically they're not aerosol producing, but TEEs I would think are pretty high risk. And certainly for some procedures like EP, where anesthesia is involved and intubation is involved, that's something that I think we also have to be thinking about, and how best to screen those patients. And if we really don't have good answers, then I think we are going to have to be very selective about which patients we bring back and use full PPE in those patients, so that we protect the staff from sort of spreading this terrible infection.
Sunil, thank you. I think you have captured a lot of questions, and in a way, you have consolidated where this discussion is heading. And I am going to Mehdi and Manas, if you are okay with this, in sort of a moderate discussion of the canned question that we had prepared. Instead of that, it might be better for us to go straight to the audience questions. Is that okay?
Sure.
Because I think that's where the money is. So I think this is a question this mainly for Dr. Patel and Dr. Storch, is that, and picking up where Sunil left, as we start getting back to our routine, hopefully, are you conceptualizing that every patient coming into the hospital for an elective procedure should be tested, or it would, based on your earlier comments, it would be limited to those patients who either display some symptoms or are at a risk of having that infection? So imagine outpatient procedures start in a week. And we have 20 patients coming in the next 3 days, and we are going to test all of them. The reason is that these tests probably, and correct me if I'm wrong, Dr. Patel, it takes about a day. For a PCR can be done in a few hours. I'm just saying, generally in a hospital, between 3 to 4 hours to an overnight turnover. Is that the range for it? And so are we going to test all the patients coming in for elective procedures? I just want to start with that. I'm sure my co-moderators will pick up on further questions along this line. Any one of you, Dr. Patel, you want to take a stab at it first?
Yeah, absolutely. Well, first of all, I want to give you some information and some hope about some science. So ASM has partnered with the IDSA, which is the Infectious Diseases Society of America, to come up with guidelines on the treatment, the diagnosis, and the prevention of this infection. And ASM is particularly working on the diagnostic part of it. We've been working night and day for about 2 weeks doing guidelines, and I bet some of you have participated in guidelines before being in cardiology, and I see some smiles. That's normally a process, right, that takes like several months, and you make your PICO question, and then you review the literature, and then you figure out if you have the right evidence and get together and rank it and so forth. Well, can you imagine trying to do this in 2 weeks and then publish the document? So we're doing it. This is the good news. The bad news is we haven't quite finished, and I have to jump off this call onto that call because one of our challenges is we keep getting new information. But the really good news about it is that we will make some pointed recommendations about who should be tested and how, and it will answer some of your questions. I can't give you the final answer here on all these questions, but I think we need to remember science as we go through this, right? We're learning as we go with the science, and one of the ways that we figure out what to do in medicine is through guidelines and review of the evidence and so forth. So that is coming, but I can't give you a preview of it because we're still putting it together, but it's going to come very soon. So I encourage you to look for that.
Dr. Patel, you know, we are very experienced moderators and we will not press you on the formal statement, but we just want to see what is your personal opinion on it. I think that's probably the best way to frame this question.
Right. So one of the questions you asked just before you made that comment was how long it takes to do testing. There are lots of different tests out there now, and it's going to depend on what's available in your healthcare facility. But I can assure you that pretty much every clinical microbiology laboratory is breaking their back trying to get testing available to you as quickly as possible. We now have tests that can be done in under an hour, but we cannot expect that every patient is going to get one of those tests. Some of them are pretty good, and some of them may not be quite as good as the tests that take a longer period of time. It depends on the particular test. So you'll want to work with your institution to understand what test is being done and the turnaround time, including not just the turnaround time, but like if you collect the specimen at this time of day, when can you expect to get that result?
And you're referring to RT-PCRs, is that right now?
They are mostly RT-PCR. There are some technologies that are not PCR, but they're nucleic acid amplification tests. I wouldn't worry about that. That's a subtlety on the laboratory side that you shouldn't be concerned about that. Really, if you want to understand the performance of a particular test, you've got to look at that test, even if it's an RT-PCR test, right? Because they're looking at different targets, they're designed in slightly different ways, and there's not a comment that I can make to say, well, if you're using this reagent or this target, then that's going to be less sensitive than another. You have to look at the individual assay that's being used in your lab. And, you know, there is a process for approval of these that's pretty clear from the FDA with EUA approvals, and, you know, the tests that are out there should, by and large, be good tests. We don't have a lot of head-to-head data comparing them. That's starting to come out now, so you'll want to pay attention to that. Now, to your question about testing asymptomatic people, I'm going to differ a little teeny bit from Dr. Storch on that. There is the presymptomatic situation, and it's true you can have pretty high levels of virus before you develop symptoms, so that's complicated, right, when you're thinking about testing your patients. Another thing that came up in our review of the literature from the IDSA and ASM standpoint is that if you have a patient who is pre-symptomatic and then you take them through a surgical procedure, a major procedure, they may actually not do well because they're in the process of coming down with a bad COVID-19 infection at the same time as you're doing your procedure, right? That's a separate issue from what we've been talking about here, but it is something to keep in mind. We've been talking about keeping each other safe and keeping other patients safe, but that patient may actually be at risk for a bad outcome too. So that's something to remember. And then I think there are patients who are asymptomatically infected who can be vehicles for transmission of the virus and will themselves never come down with symptoms. And that's complicated because if they're there undergoing a procedure, then you need to make sure that you're protected from them, right? And really, the first and foremost way of doing that is with PPE. We just don't necessarily have enough PPE everywhere to do what's needed. And so diagnostic testing should not be an excuse to not use proper PPE, right? I think that's very important to understand. But it can be helpful in identifying those who are infected versus those who are unlikely to be infectious at the time of your procedure.
I'd like to follow Subhash on that question, and if you will, Dr. Patel and Dr. Storch. You know, many of us, many of my colleagues have heard a lot of conflicting news, you know, from CDC, maybe from our own organizations, maybe from the societies, and the level of confidence in some of the statements from CDC and other societies, the level of the confidence of folks to these has gone a little bit down, because like 1 week, you don't need PPE, the next week you need PPE, even though the virus has been the same. So my question to you is that in the ideal world, and I want your personal opinion if you can give it to us, if it was ideal and we did not have a testing problem, testing was not an issue, who should be tested when they come to the hospital or to clinics? Can you comment on who should be tested if testing was not an issue?
Well, let me jump in with that and say that I think it's very important to understand the assets, but also the limitations of testing. And here we're talking right now about the virus testing.
Yes.
Most of the indications are that those tests are only about 70 to 80% sensitive. And clinicians taking care of COVID patients have fairly regular experiences with patients who test negative and then are retested several days later and test positive, or are negative on a nasal sample, but positive with a lower airway sample. So we have to understand that the negative predictive value of a test, of those tests, is not that high. And so you must really not think of them as the primary protective measures for you and the staff. The primary protection is personal protective equipment and good technique. And the testing can only be an adjunct to that because of the reality of the limitations of the sensitivity of the testing.
I agree with that, absolutely.
So in general, just to summarize then, you know, because we just had this discussion actually in my own organization yesterday, and we're trying to see what the best approach is. There are some of my colleagues that are very gung-ho about testing, and even though it still is not widely available for us. And but I think that the emphasis should be on PPE. Given your infectious disease experience, I guess the challenge we have is that we don't have N95. Can you just, I know the topic is testing, but since you guys are expert and you're raising this issue of PPE, given the situation about the pre-symptomatic and asymptomatic, and knowing that the testing is not ideal, as you have kindly pointed out, what is considered good protection? Are we still, is it N95, or, you know, these surgical masks are enough even when you're going to be in a close contact with the patient working in less than 1 to 2 feet for maybe an hour or maybe more?
That's a tough question.
Yeah.
The CDC's position on this is that an N95 should be used when there is an aerosol generating procedure. And if there's not an aerosol generating procedure, then the use of an N95 is optional. But it's acceptable, at least in the CDC's eyes, to use standard surgical mask if you're not doing aerosol generating procedures.
As I mentioned, there will be an IDSA guideline coming out on this issue as well, prevention. So look for that. I know that it's coming out probably around the same time as the diagnostics guideline.
So I'm going to pick up to some very brief and factual questions from the chat line, which are quite interesting. And Manas, if you are looking at them, would someone who is infected with coronavirus 2 have a positive seasonal flu test? These are just brief responses.
Oh, yeah, it's possible for someone to be infected with SARS-CoV-2 and another virus or a bacterium. That certainly occurs. We call it co-infection. So that means that the detection of one agent doesn't rule out the possibility that there's another agent there.
Dr. Storch, one quick one for you is that patients who we are hearing a lot of news about reinfection. What kind of test, if one had to pick one, would we pick for detecting reinfection? If someone is worried about reinfection, what would be the test one should do in that situation?
Well, let me say, I think the issue of reinfection is still very open. And the studies that I'm aware of that you may be referring to are studies that follow patients after they've had a documented case of COVID and have had a negative test in the recovery phase, but then shortly thereafter are found to have a positive test. And I don't think we know yet whether that really signifies reinfection or just that the level of virus is very low and near the level of detection, limit of detection of the test, so that certain tests might just by statistical chance be positive or negative. So I think it's still not established whether there is reinfection or not. But if you were going to look for reinfection, the virus test, the RT-PCR or nucleic acid amplification tests would be the tests to do.
Sunil, a quick one for you. Go ahead, Mehdi.
I want to ask a question from Sunil. In talking to some of my colleagues, Sunil, interventional cardiologists, and we had a meeting last night for 2 hours. So I have all the questions fresh. One of the concerns they have is that for most of the procedures that we do in the cath lab, we are about a foot and a half away from the, at least the face of the patient if we are working in the radial or groin area. But one of the concerns that many of them have raised is that at any moment, things can get crazy, right? We may have to do chest compression. We may have to intubate the patient. And, reality is that most of the colleagues that I talk to, they really don't have an N95 mask. They don't, we have some protection, but we are not protected in a way that, that would be maybe appropriate. I don't know. I mean, most of these patients, we think they're COVID negative, but they are not tested. We only know that we think they're negative because they're asymptomatic, whatever, at least based on fever and cough. I guess, and I saw this SKY document that was recently released, and many of my colleagues had many questions about it and all of that. But your personal insight into what do you recommend to our colleagues that may be having this fear and this challenge as we treat our patients?
Yeah, I think it's a really good question, and I can give you my opinion, and I think that as this disease continues to evolve, hopefully we'll get more data on this. My personal opinion is that there is a gradient of risk for the procedures that we do, and if you're on call and you're dealing with a STEMI, obviously the risk of someone decompensating acutely is a little bit higher in that case, and I think that it would be extremely reasonable to go with full PPE when you're coming in for a STEMI, particularly because we don't have any rapid rule-out tests that are largely being used across the country in these STEMI patients. I think one of the mantras that has come out from folks that are in New York City who are really on the front lines of this is that there's always time to put on PPE. It doesn't matter. I mean, even if you think it's an emergency. So. Again, I don't think I'm telling anyone anything that they don't know, but again, we have to underscore the fact that if you are dealing with someone where you think that the risk of decompensation and intubation is high, really, take the time to put on the appropriate PPE before you do that case. Now, elective cases, I think, are a little bit different. I think the risk is considerably lower in that situation. And so, again, my personal opinion is that if the patient is wearing a surgical mask, and you're wearing a surgical mask, the risk of transmission in someone who is, does not have fever, cough, or has had a recent exposure to a COVID patient seems relatively low, and that's certainly what I've been doing.
Can I ask you more specifically, what do you wear for the ST elevation of mice? Do you mind sharing with us how do you protect yourself?
Yeah, I think an N95, a surgical mask over that, and then making sure that you're following the appropriate donning and doffing protocols. We have a COVID room, just like many of you do, and we've had really team sort of meeting to make sure that we've got the appropriate ante rooms and patient flow to make sure that we minimize the exposure of anyone, because these patients don't stay in the cath lab, they go to the CCU. So if you've got a positive pressure room, you open the door, all of the air goes out into the hallway. So those are the kinds of things that you have to think about. We're several weeks into this, so I imagine many of you have already thought about it. But if you haven't, I mean, that's really what you have to pay attention to, and make sure you have a dedicated room and you work with your infection control people to make sure that you've got appropriate ante rooms to don and doff and make sure that you can transport the patients in a safe way.
Can I ask a quick question, for Dr. Patel and Dr. Storch? So for healthcare providers, I know that if you're symptomatic, you'll be tested at work, but as you know, tests are not in little supply. Let's say you're worried, but you're not really symptomatic. Should you get tested? And if yes, how do you do that?
So you said you're worried, but you're asymptomatic?
Yes, no symptomatic, but you've been exposed or whatever, you're still worried that you may have been clinical.
Yeah. Well, if you've been exposed to the virus and you're a healthcare worker, your occupational health services should be providing you recommendations. And one of those should be likely, if it was a true exposure, not coming back to work for a period of time. There is also testing that could be considered, but if you've been exposed, then you may contract this virus. And one of the challenges with it is there's this delay that happens. If you are going to acquire the infection, you're not going to know, the next day, oh my gosh, I got it. It's going to take you some time, if you're going to develop symptoms, to develop those symptoms. So you won't know that you're out of the woods for quite a long time down the road. So you need to work with occupational health to discuss that exposure. Whether that exposure honestly was at work or not at work, that needs to be discussed, because you may need to stay home for likely 2 weeks. And whether or not you get tested is another consideration, but I don't think a test is going to release you from that not coming to work piece.
Right. You have to keep in mind that during that pre-symptomatic period, for most of that time, the test is going to be negative. So it will not tell you whether after an exposure, you're actually in the process of developing the infection or not. That's just a limitation of the test. Now, depending on the nature of the exposure, many places will choose to allow people to work, but to screen themselves very carefully for symptoms, and only stay home from work if they start to develop symptoms.
I want to get to some of the questions from the chat room. I think there is a very important one. In an individual or a patient, when the viral RNA detecting tests is positive, and the patient has actually recovered from the infection, when does the test actually turn negative? Or does it ever?
It does turn negative, and it's going to vary from patient to patient. Remember, though, that viral RNA test is not necessarily detecting infectious virus. So we don't have a good way of knowing for sure. But if they're still testing positive, which can happen for some time, it can happen for several days, if not weeks, in infected individuals. That should be a signal of possible concern as far as transmission.
Dr. Storch, you have a point. Do you agree with Dr. Patel? I'm trying to stir up some controversy here, but.
Well, no, I fully agree with that. I think in most patients, the PCR will be positive for 2 weeks or more, and sometimes for several more weeks beyond that. And there is a phase where if you were doing cultures at the same time, that probably correlate better with infectiousness than the PCR, the cultures would turn negative while the PCR is still positive. But if you're only using PCR, you won't have a rigorous way of distinguishing between those infectious situations and non-infectious situations.
Because both our experts are agreeing, let me get to the very controversial parts of my prepared questions, because I'm unable to trigger debate here, and you guys are so well tuned to each other. So I read the CDC document about PCR. I'm going to read out a sentence from there that utterly confuses me as a cardiologist, and we tend to be very simplistic in our understandings. It says on one part that it is considered the gold standard test. They've actually used it in one of the JAMA publications. Oh, yeah. And on the other side, there's also a statement that says that a negative molecular test, and I'm reading this, and I quote, does not rule out COVID-19.
Yeah.
Specificity also varies by the stage of disease, So negative tests should be interpreted in the context of the exposure history and symptoms. This is way beyond a cardiologist can understand. So
no, a cardiologist can understand this, first of all. I'm sure it's no problem. You know, one of the issues that we, coming up with the diagnostic guidelines, really wrestled with, and I think we're going to either include a statement on this in the guidelines or write something separate, is that there is no gold standard. There is no reference standard for this disease, because we know patients can be sick and test negative. And a lot of times people are evaluating the assay itself. They cannot be using the assay they're evaluating as part of the definition of the disease itself. That just gets very complicated. You might use other assays. But fundamentally, we don't have a reference standard to say, this group of patients definitively has this disease and this group of patients does not. And that's the challenge in terms of defining clinical sensitivity, right? To define the true clinical sensitivity, you'd have to have another way of classifying your patients as having the disease or not having the disease. Me personally, I do research in a different area, and that area suffered from the same problem of absence of a reference standard. And probably in cardiology, you have something like this as well, right?
We absolutely don't. We have everything standardized perfectly. And
Everything's perfect? Okay, well, anyway, that's really strange. But in infectious disease, this certainly happens. And so that's where you hear those statements. I think what we can say is that the viral RNA tests done on the right specimens are the best tests we have. And maybe that's what they meant by gold standard. But they are not the reference standard, because you can certainly have patients who have this infection who test negative.
Thank you. Dr. Storch, where do you disagree with Dr. Patel? Let me ask you the direct question. I'm kidding. But your position on this?
Well, I would just add that it may be that the antibody test will actually help us by providing a standard that we can compare PCR to, because most patients, when they experience a viral infection, do develop an antibody response. And so if you wait 2, 3, 4 weeks or so from the initial infection and then get a serum sample and measure antibodies, that will identify the group of patients who had the infection. And with that as your gold standard, you can assess the sensitivity of PCR. And I'm quite confident that it's going to turn out to be significantly less than 100%.
I completely agree with that. I mean, I think the reference standard has to be set perhaps based on some clinical parameters, but also with that follow-up of patients to see who goes on to seroconvert or develops those antibodies is a great way of getting at the ground truth of who actually was infected and who was not. But then the PCR would have been earlier on in that time. So you really need to follow a population, right, to be able to then categorize the truth of who had the infection and who did not have the infection. And one of the challenges now is everybody wants everything like right now, right? Your diagnostic test, we want to know this answer right now. We have no time to follow populations. I'm pretty sure in cardiology you follow populations, but we don't have much time for that. But that is exactly right. I'm going to completely agree with that. That would be a very nice reference standard.
So while this is going on, one last question, Manas. While this is going on, if someone is resequencing the genome, the actual of the virus, because this could change, it would mean all the testing would be not valid at a certain time point. Could you elaborate, Dr. Patel?
Yeah, there are lots of efforts going on sequencing the virus. Much of that is being done for epidemiology to track small changes in the virus that will hint at where it's been and how it's moving around, right? But it also allows us to interrogate the regions that are being targeted by the diagnostic assays and make sure that they're continuing to function. So certainly there's a lot of sequencing going on. Not every patient, obviously, with this infection is having their virus sequenced, but there are a lot of activities going on that front.
Thank you. Manas?
Well, one quick question for Sunil and everyone else, I think echoes many people's worries, which is how do we protect our family when we go home? We've been in the lab, we've been wearing the protective equipment, we had the cases with or without COVID, we go home. What do we do, or what do you do right now to minimize the risk of your family getting it?
Yeah, I think it's a great question. I think there are folks, again, who are in the COVID-19 hotspots who probably have a different level of protection and strategy when they get home. I can tell you what I'm doing. I mean, like I said, we're not an epicenter right now. We are seeing a slow uptick in cases in North Carolina. If I am in a situation where I'm seeing patients, whether they're PUIs or just people who are clearly not under suspicion, I'm generally changing into new scrubs before I leave the hospital. And then as soon as I get home, I'm showering before interacting with my family. If it comes to the time where, we are going to have to go, the hospital gets full and, all of us are getting pulled to take care of COVID patients, I think in that situation, my personal view is that I would probably just sequester myself to another part of the house and just sort of, minimize the interactions as much as possible until all of this is resolved. Honestly, that's probably a question better for folks who are in New York City or in Detroit who are dealing directly with that. But my own conversations with them seem to reflect what I've been telling, what I've just said to you, which is that, if you're really dealing with the COVID positive patients, you're probably better off just sort of staying away from your family until you're sort of off the service and a few days have passed.
Sunil, the concept behind this arranging this webcast actually started with a very simple question that most of our patients that we will be seeing in non-pandemic areas, non-epidemic hotspots like Dallas, Texas, and Durham, and we are going to do a lot of procedures on low-risk patients who do not proclaim any symptoms that are suggestive of any COVID-19 infection. Should be routinely testing. And I know you are not going to speak on behalf of Duke Medical Center or the VA hospital, but if you had your choice, would you test every patient, low-risk patient, and let me clarify that, in a non-epidemic hotspot coming to your cath lab or echo lab for everyday clinical outpatient visits to test them before they come in? Yes, no, or there's a variable answer?
Yeah, so my personal opinion is no. I think that, again, given what we know about the operating characteristics of these tests and how it depends on the prevalence of the disease, I don't see how that's helpful to me, aside from providing me with some false level of reassurance that, and what I think the danger of that is if you do have a false sense of reassurance, you may get a little sloppy in how you're protecting yourself in the hospital. And so my personal opinion, and that's all it is that I think that if you're in a low prevalence area, I really don't see the utility of routine testing.
Manas, this is not common, but I always have reached out to you with tough questions. But what is your take on it? If you had the choice, would you test in Minneapolis low-risk patients coming to the lab without symptoms and coming for echo lab practices, echo studies, cath studies, outpatient visits? Would you proactively go and test each one of them because you have the luxury of time?
Well, I mean, if you ask me, and again, I'm not the expert, obviously,
yes.
But for me, I mean, yes, I would, because there's a few people who are asymptomatic and they may be transmitting the virus, who don't know it, and the only way to find out is by actually doing the test. So if we had unlimited tests, I would test every single person the day of the procedure before they come to the cath lab. So if they're positive, then we stop the procedure.
Understood. And the second question, I'm just asking this for a specific purpose. So Sunil, back to you, because I don't have Mehdi here and we can't do a poll, and we should probably, is that would you test, again, your personal opinion, healthcare workers in these hospitals periodically? People in the cath lab, say, for example, and there has been a patient, they have been exposed, or not exposed, but would you periodically survey healthcare workers in a hospital with repeated antibody tests or some other tests?
Again, and maybe I'm at one extreme, but I would not. I don't think I would. I think that, careful attention to exposures and symptoms are probably, and then making sure you're practicing very, very good hygiene, washing your hands frequently, not touching your face, et cetera. Although I did count, I think I touched my face 5 times during this webinar already. But yeah, I think those kinds of things, I think if you're doing that, I personally would not test. I certainly wouldn't, I can still understand someone who would want to test, but I personally would not.
Manas, do you have a different take on this? Would you do that for healthcare workers in a hospital, even if they are not symptomatic, to survey them periodically?
Well, I think I echo, that's what Dr. Patel had said before, that, it's even if you're negative, you may still be getting it. So I think there the value is probably less.
So Dr. Storch or Patel, we're coming towards the end and actually exceeded our hour, and we still have questions coming. I'm trying to ask this question and summarize some of the thoughts that are coming through the chat lines. Feel free to respond to them if you are able to. But it does, the positions that Sunil and Manas just outlined regarding testing of low-risk patients coming to cardiovascular practices, I think is kind of highlights the dichotomy of our thought process and the positions we are in. I think these responses could be very different, like Sunil pointed out, if someone is in a hot spot, and that question is completely out of the scope of this conversation. But imagine we are in non-New York City, non-Northeast states. We are in Texas and Midwest United States and Durham. Would it be your personal, again, not a societal recommendation, not on behalf of any organization or institution, that low-risk patients who are coming to cardiovascular visits for hospitals and procedures should be routinely tested? Dr. Patel, just your opinion, and Dr. Storch again, as we head towards the close of this session.
Yeah, I completely agree that you need to keep in mind how common this virus is in your community as you come up with guidelines. You need to keep in mind how available or not PPE is at your institution, and testing obviously as well, although we need to be doing what's right and really aiming to get there rather than making excuses for not having things that we don't have, right? We need to figure that out. And then lastly, I think you need to look at whether the patient's going to stay in the hospital or not, and whether this is going to be an aerosol generating procedure or could become one during the procedure. And if it is, who in the room, because I suspect you're not alone in the room when you're doing these procedures as well. And you may need to think about, are you going to do different things in terms of PPE and so forth for different people, and you factor testing into that as well. So I think it's a little bit more of a complex equation than just a straight yes, no answer.
Thank you, Dr. Storch. Questions to you, same questions, surveillance of low-risk patients and surveillance of healthcare workers in a hospital.
Well, as far as the patients go, I think if you're not in a high-risk area, I think what you'll find is that the frequency of positive tests in asymptomatic patients, first of all, will be very low. So your yield is going to be low. And secondly, you just have to keep in mind that that test will not be reliable at picking out those individuals who are asymptomatically infected. So you must maintain universal precautions at all times, regardless of the results of the test. And that would lead me to be against routine testing in low prevalence areas. Although I think Dr. Patel made an important point. If it's a patient who's admitted or going to be admitted, then there may be an additional reason in favor of testing, because depending on the hospital, they may have different bed placement practices for COVID positive patients and COVID negative patients.
But so to summarize, I think Manas, you would agree that most of our panelists, the two experts especially, and I think are saying that for routine visits of low-risk patients to a hospital when we open up, I think routine everyone being tested in that scenario in a non-epidemic hotspot is probably not worth our while. That's what the message is. And second is that similarly, that testing and repeat testing of healthcare professionals in an institution where there is no concrete exposure just for the peace of mind probably is not the right way to go for various reasons. And included in that reasoning is also the availability of such testing. Is that a fair conclusion, Dr. Patel?
Yes.
Dr. Storch, do you agree with that general summary?
Absolutely. And I do think we have to keep in mind the issues of test availability. You know, everybody on the globe is looking for testing and for all the components that go into the testing, the swabs and the transport media and the various reagents. And I think we all have to be responsible about how we use testing and not use it in very low yield situations.
in my final question, in the CDC's Q&A, there is a section about home-based testing, not point-of-care testing. And are there any home-based testing that are available in the US or around the world? And this is not a funny question, but this is a serious question. And if there are such tests that could be possibly done at the home.
So there are several possibilities here. One has to do with viral RNA testing with self-collected specimens. And certainly there is some data in the literature to suggest that patients can collect their own samples or parents can collect their child's samples. It's really difficult to do a full nasopharyngeal swab all the way to the back, but there's something called a mid-turbinate swab that can be used to collect your own sample, or alternatively an oropharyngeal swab. So that's possible. The testing itself would not be happening in the home because there's no home PCR test, for example, but the specimen collection could potentially be set up that way, right?
Home collection of specimens.
Yeah,
and send it
and
over.
then you may, I don't know what's out there for serology tests, but I don't really see the rationale for home testing with serologic tests, but there certainly are ways to collect your own blood, like with a dried blood spot, a finger prick at home, and so forth.
Thank you. Sunil, any comments from you, Manas?
No, I just want to thank Dr. Patel and Dr. Storch. I learned a lot, actually. It's terrific. Thank you.
Yeah, I agree. Thank you so much. It was very informative. Really appreciate it.
Thank you very much, Dr. Storch. Thank you very much, Dr. Patel. Thank you, Sunil, very, very much. And Manas and Mehdi, on my behalf and Paul's behalf, thank you all for being with us today and sharing your thoughts. As you can see, we had close to 188 logins on the live webcast, and this will be also posted at cvinnovation.org, and you'll be able to access it and share it widely. Thank you very much.